Welcome back to Cardiology, Part 5, Congenital Heart Disease. We sort the left to right shunts, the cyanotic defects, and the two phases of coarctation. Let's go. We start with the two classic left to right shunts, atrial septal defect and ventricular septal defect. The heart sounds split them. An atrial septal defect gives a wide, fixed split-second heart sound that does not change with breathing, plus a systolic flow murmur from the extra volume crossing the pulmonary valve. The most common type is ostium secundum, while ostium primum is linked to Down syndrome. A ventricular septal defect gives a harsh holosystolic murmur at the lower left sternal border, often with a palpable thrill, and counterintuitively, the smaller the defect, the louder the murmur. A VSD is the most common congenital heart defect, and a large one left unrepaired can reverse into Eisenmenger syndrome. So a wide fixed split-second heart sound is an atrial septal defect, while a holosystolic murmur at the lower left sternal border is a ventricular septal defect. Now patent ductus arteriosus versus coarctation of the aorta. One announces itself with a non-stop murmur, the other with a difference between the arms and the legs. A patent ductus arteriosus keeps the aorta connected to the pulmonary artery after birth, giving a continuous machinery murmur below the left clavicle, bounding pulses, and a wide pulse pressure. It is common in premature infants, and indomethacin closes it while prostaglandin keeps it open. Coarctation of the aorta is a narrowing that raises the blood pressure in the arms but leaves the femoral pulses weak and delayed, with an arm-to-leg pressure gradient and, in older patients, rib notching from collateral vessels. It is linked to Turner syndrome and a bicuspid aortic valve. So a continuous machinery murmur is a patent ductus, while an arm-leg pressure gap with weak femoral pulses is coarctation. Two ways a child turns blue. Tetralogy of Fallot versus Eisenmenger syndrome. The timing of the cyanosis is the key. Tetralogy of Fallot is a primary cyanotic defect, blue from early life, with four features: a ventricular septal defect, an overriding aorta, right ventricular outflow obstruction, and right ventricular hypertrophy. Kids have TET spells and squat to relieve them, and the chest X-ray shows a boot-shaped heart. Eisenmenger syndrome is acquired, a long-standing left-to-right shunt like an unrepaired ventricular septal defect. Atrial septal defect or patent ductus slowly drives pulmonary hypertension until the pressure reverses the shunt to right to left, and only then does the patient turn blue with clubbing. So cyanosis from birth with a boot-shaped heart is tetralogy of Fallot, while cyanosis appearing late after years of a shunt is Eisenmenger. Three early cyanotic lesions that are easy to blur: Truncus arteriosus, tetralogy of Fallot, and transposition of the great arteries. One trunk, one obstruction, or two swapped vessels. Truncus arteriosus is a single arterial trunk sitting over a ventricular septal defect. So systemic and pulmonary blood mix in one vessel, giving early cyanosis and heart failure. Tetralogy of Fallot has two great arteries but an obstructed right ventricular outflow with TET spells. Transposition of the great arteries has the aorta and pulmonary artery switched, creating two parallel circuits that do not talk to each other. So the newborn is profoundly cyanotic and survives only if a mixing lesion lets blood cross. Prostaglandin keeps the ductus open until surgery. So one trunk is truncus, obstructed outflow is tetralogy, and two switched parallel arteries are transposition. We close with the two phases of coarctation, the infantile preductal form and the adult postductal form. One crashes as a newborn, the other is found years later. Preductal or infantile coarctation narrows the aorta before the ductus arteriosus, so the lower body depends on flow through the ductus. When the ductus closes in the first days of life, the neonate goes into shock with lower body hypoperfusion and differential cyanosis, and you keep the ductus open with prostaglandin. It is the classic coarctation of Turner syndrome. Postductal or adult coarctation narrows after the ductus and is found years later as upper extremity hypertension with weak, delayed femoral pulses, a radiofemoral delay, and rib notching from collateral vessels. So neonatal collapse when the ductus closes is preductal, while an adult with an arm-leg pressure gap and rib notching is postductal. Lock it in. Shunts, a wide fixed split-second heart sound, is an atrial septal defect. A holosystolic murmur at the lower left sternal border is a ventricular septal defect. A continuous machinery murmur is a patent ductus, while an arm-leg pressure gap with weak femorals is coarctation. And for cyanosis, blue from birth with a boot-shaped heart is tetralogy of Fallot, while late cyanosis after a long-standing shunt is Eisenmenger. Among the early cyanotic lesions, one trunk is Truncus arteriosus. An obstructed outflow is Tetralogy of Fallot, and two switched parallel arteries are transposition. And coarctation has two phases. Neonatal shock when the ductus closes is preductal, while an adult with an arm-leg pressure gap and rib notching is postductal. That is part 5. Part 6 finishes the series with vascular disease and the vasculitides. See you there.